to welcome everyone. I wanted to welcome everyone back. I hope you enjoyed your lunch. This afternoon, we're privileged to have Chief Randy Kolentus with us. Chief Kolentus, CHPA, is the Chief of Police for Reid Hospital and Healthcare Services in Richmond, Indiana. Reid is a 225-bed regional referral center with a level 3 trauma center with over 3,500 employees throughout a 9-county service area. Randy is married to Carrie and has 2 daughters, Anna and Ellen, along with 6 grandchildren. Carrie, Anna, Ellen, and son-in-law Mike also work for Reid Health. Prior to joining Reid, Randy served 29 years on the Richmond Police Department from 1978 to 2006, serving in a variety of roles and responsibilities, including assistant chief. When Randy joined Reid in 2006, the Reid Security Department consisted of 7 security officers. During his leadership, the department has expanded to 24 officers. In 2009, Randy received his Certified Healthcare Protection Administrator status through the International Association of Healthcare Security and Safety. 2014 through 2020, Randy served as the chair of the IHSS Indiana chapter. In February of 2020, with support from local law enforcement agencies, Randy received governing board and executive leadership approval to transition the security department at Reid Health Police Department with certification through the Indiana Law Enforcement Academy. March of 2021, Randy was designated a Sagamore of the Wabash from Indiana Governor Eric Holcomb for over 44 years of community and state service. Chief Kolentus has been a presenter at our IRHA risk managers directors meetings in the past. He is always quite generous with his time and resources. So please join me as we welcome Chief Randy Kolentus to our program today.
Thank you, Phil. Thank you all for having me this afternoon. I'm going to have a presentation on active shooter and policy and stuff like that. So I hope it's interesting, and I hope it's information that you all will find of some value in. It's things that I have learned and picked up over my years of service, especially over the last 15 years with my involvement in healthcare. We'll start off on the first slide. If you want to go on to the next one, Phil, there we go. We're going to touch base on these items here: active shooter policy and planning. A pretty important piece of creating a policy. Depending on the size of your facility, all facilities should have what would be known as a master plan that kind of covers all the bases. But then each department within the facility should have their own policy statement on what their particular staff would be doing if there's an active shooter involved in the facility. Another thing, as we go on, all emergency codes in healthcare in particular, in those settings, they should all be pretty much plain talk. You want to try to stay away from code words and code descriptions. For instance, here at Reid Health, our active shooter is called active shooter. That way, if we have visitors, patients, everyone would be aware of what's going on in the facility. Not to alarm folks of what's going on, but to alert them so they understand what staff would be doing, and potentially they would understand what they would want to do as well if they're involved or near a situation like that. So plain talk on all codes is very important. Communication and drill anxiety are kind of a critical piece too. If you don't communicate enough about the active shooter plan and how it's going to work in the facility or how it should work, then your staff aren't going to know how to perform or what to do. Back to the policy and planning piece too, the department specific plans need to be very limited. You want to be very specific of what staff in a certain area need to do at that particular time. If you complete a master plan policy and expect all of your staff to review that and understand it when an event occurs, they're probably not going to do that. It will not come out the way you plan it. That's why department plans need to be just that specific for staff, so they understand what they're doing at the time. We have experienced during our drills that we hold here some staff anxiety, and it's a very real thing. No matter how soft you try to play a drill, it still gets people kind of shaken a bit. We have in the past used Reid employees as the active shooter. And we have them put on a t-shirt that identifies them as a drill participant, active shooter. We have folks around them with signs that are holding signs up that actually say to anyone around that they see and understand that we're having a drill. But still, the staff that we approach with that sign and ask them what they're going to do or what their response is, they really get pretty nervous. So yeah, that's another piece you have to consider, because you don't, during these trainings, you don't want to turn staff upside down. And you try to do that. We try to do that here, so we don't upset people, but we still need to get the point across during a drill of what could be happening. We'll cover too what an active shooter definition is, and this is something that's put out by the Department of Homeland Security. We'll talk about that here in just a few seconds. Identify high risk areas. That's an important piece for each facility. In our hospital here, certain areas that are high risk are considered, and they're also documented in the policy, the master plan policy. Administration, human resources, emergency department, our family birthing center. But our family birthing center is a tightly locked unit, but that doesn't mean something can't happen within that unit. So you kind of identify high risk areas in your facility and where the potential might occur for a disgruntled patient or a visitor or some type of event. Understand, and we'll have the slide up in a minute, understand some of the potential violent behaviors. And these are things that staff could see present in either a visitor or a patient that might be leaving that's not real happy with their care, that comments they might make or behaviors. The same with our staff. We always have to be vigilant on what our staff are doing. We have I have folks in this department that I work with daily, talk with them daily and kind of understand what's going on and hear things that are going on with them or other officers in the department. So those are things, key elements that we have to try to keep track of, understand, and see if and when we might need to get involved. Staff's response is going to be directed by the policy that's created by each of us. The training and the policy go hand in hand. Like I said earlier, it's like you have to make sure that staff understand their response, understand how critical that response is. But the outcome is still going to be controlled by each individual staff person. We can train a lot, we can train every day, but when an event would happen, there might be a different reaction. So it's also going to be controlled by the individual. And I think that would be much the same on all emergency codes that we have in hospitals, private practices, small facilities, whatever we have, it will be directed that way. We'll also talk a bit about what to expect from law enforcement and how law enforcement will react to the shooter and the shooting situation. And the next piece we'll discuss right now, I guess, trainings across the country. That run, hide, and fight is the big thing for active shooters, and that piece was addressed by Department of Homeland Security, Emergency Preparedness, U.S. Department of Health and Human Services. A whole bunch of folks have looked at that. They all decided that run, hide, and fight best fits, because their belief in that is that the first thing you want to do whenever there's any kind of gunfire like that or an active shooting situation is you want staff to run. Want them to get away as best they can. If they can't get away, you want them to hide somewhere that they can secure themselves, and as the very last resort, to fight. So that's what's been promoted for many years, and Department of Homeland Security drove that for a while. But we did have a group of physicians that came along, I believe in 2019, and they kind of came up with a different kind of wording for healthcare in particular, and it's called secure, preserve, and fight. And the reasoning behind that was somewhat statistical, but also for the staff that are involved, in physicians and clinical staff. You know, they take their oath of what they're going to be doing to save, protect, and all that for patients, and so they kind of take that very seriously. And some staff, physician and clinical staff, feel compelled that they would stay with patients, and some patients in particular that are needing constant care for life support, that they would not leave. So this group of physicians came up with secure, preserve, and fight in an effort to better protect the patient, and also try to protect the staff that did not feel running was the correct option. So they have put that out there. They say it's a lot different in the healthcare setting than it is in like a shopping center or out in a public area, which does make sense after reviewing some of the statistical data that I've seen over the years. I've got a couple papers, but one of them is they're pretty old studies, but one was in 2012, and between 2000 and 2011, they went back and looked at all shootings that were healthcare related, not necessarily a mass or active shooting situation, but a situation where one person or more were injured with gunfire. And just in that short period, there were 154 incidents in 40 states. The death or injury was pretty high at 235 people. I believe the reason these aren't national news is one, because it's healthcare, and two, it may not have fit the criteria for the Department of Homeland Security for what they consider an active shooting event. My thought on that is, with some of the different types of shootings that have occurred in healthcare, if the person that's doing the act gets cornered or in some way getting delayed from maybe escaping, that may turn them into an active shooter where they just have to start shooting more people. So, you know, I'm not involved in the creation of the numbers, but I found that pretty interesting. And then from 2000 to 2017, document like 250 events. And of those events, there were only 10 that were healthcare related. And that is another piece that those physicians put out there as why we perhaps should secure first and preserve and fight last, as opposed to run, hide, and fight. Just knowing that the 10 events out of the 250, that does kind of give some validation to their consideration on secure, preserve, and fight. But on the other hand, run, hide, and fight is still what's promoted most at this point. So just throw that out there for you. Moving on to the next page that you've got there, Phil, that's perfect. On standalone facilities or facilities that don't have on-site security or law enforcement officers working, I've often told folks that you need to reach out to local law enforcement. You need to find out what officers are working. If your facility is open 24/7, find out the different shifts. If it's just like a first shift operation, then you want to reach out and touch base with those local law enforcement officers. Have them come in some point maybe review a policy that you create, get their input on it, and then at some point maybe invite them to walk through the facility with you to determine good egress points, good points to hide, and areas that you might be able to pull visitors into and lock them in as well. The first priority in any policy creation, I think, is staff. Because once everything is over and things are trying to go back to normal, you want to make sure the staff are okay. So staff would be the number one priority. The second is patient and visitors. And obviously the third priority would be the facility. The facility can be redone, reworked, new drywall, whatever we need. That can be done much after and is really not a priority at the beginning of these events. I point out some of the threats that we've had here at Reid Health over the past year. You can see we've had medical staff that have been threatened by patients and family members. Sometimes our staff get threatened by large groups. Obviously with COVID going on, we don't have large groups much anymore, but we have had in the past year where we've had families that were end of life type situations, and we did allow them in. Sometimes our staff get intimidated by that group. We had a patient in our medical office building that was very threatening to staff and the physician. That person was eventually banned from the facility and escorted out. Doctor shopping is a big thing. And we have a great bunch of physicians here that are very quick to catch those kinds of things, and they don't participate or allow that. And sometimes those patients or those folks looking for different drugs become threatening, but they're also escorted out. But demanding drugs is a somewhat popular thing. I'm sure it's here and in our off-campus critical care that we have a emergency department centered from there. I'd like to talk too about stages of crisis development. All patients and visitors that are coming to a hospital, our hospital in particular, are always at this first stage of the anxiety for a number of reasons. You have people that are coming in because their doctor sent them out here. They don't know what's wrong. So as soon as they hit the door, they're nervous or upset, wondering what their diagnosis is going to be, what else might happen. The same way with visitors. When visitors are coming to see someone, they're not clear. It could be something pretty simple, but it might be something that hospitals are doing testing on the person, and they're nervous and upset as well. So we all in healthcare need to understand that and pretty much be ready for each visitor that comes in the door to be a little anxious. And I think when people are anxious, sometimes that their worst side comes out. So try to teach staff and have staff ready for that kind of thing. And I think that would hold true as well in off-campus buildings, doctors' offices, and just general practices. And if people that are coming in there, they're not going to be happy to have to wait. So all staff need to kind of understand these stages of crisis development and what their response would be. Defensive stage is when a person starts to challenge everything that's going on. Why is it taking so long? When am I going to get to see the doctor? Those kinds of things. And you need to have staff to understand what their reaction would be on this. Staff need to be direct and need to be able to work with or talk with the person to try to de-escalate the person, to get them to calm down a bit until their appointment time is up and they're ready to be moved back. But using de-escalation skills as well. Once they get to an acting out or loss of control, that's when they're very aggressive. They're demanding, they're throwing things, they're yelling, intimidating other visitors or patients that might be in the waiting rooms. And at that point, we've lost control. So at this point, if it's an off-campus, past time to call 911 to get some law enforcement help. It's probably past time if you have on-site security to notify them as well. That should always be best done on the defensive stage. Never hurts to make a phone call and get someone coming, even if you have the opportunity to de-escalate at the defensive stage and accomplish that before it escalates to the acting out. The last stage is the tension reduction, and that is just an opportunity for caregivers to go back into that mode of caregiving, try to communicate with this person again to get them understanding what is going on, and ask them how they are. We want to make sure they understand we are, once again, taking care of them to make sure that they're okay. Next slide. Talk a bit about verbal communication. It's really important, especially as someone starts to escalate their behavior, that we control our tone. You always want to try to speak calmly and speak in a low tone, even if that person is escalating and starting to yell. It never has a good outcome when we start yelling back. In fact, that oftentimes escalates what's going on. Nonverbal communication, that's your personal space and what you're doing with your hands, other actions. If you're dealing with somebody that's escalating, you want to make sure you don't look away from them. You want to focus on them. Make sure that when they're looking at you, they see you looking at them. You're looking at their eyes. That way they know that you're paying attention to whatever their problem is, that you're there maybe to help them. But if you start looking away, that's going to agitate or cause the situation most likely to escalate. You also want to keep your personal space. We all should have a personal space that we're comfortable with, especially when we're dealing with somebody that's being a little more aggressive. That space probably would increase with most of us. Blade your body so we're not standing square on with a person that's being aggressive, and make sure you're kind of protecting yourself if something would happen. But remember too that everybody has a personal space. Even the person that's being aggressive, they have a personal space. If we get too close before we really need to be close, that could cause the situation to escalate as well. Safety is number one priority, and that's for everybody. That's for the patient involved. That is for staff and visitors as well. Anyone around you, you want to make sure that everybody's safe by using some de-escalation techniques. Never go one-on-one with a person that's being aggressive. That's not a safe thing to do. You always want to make sure you have other staff available, or at least other staff that know what you're doing. Your personal safety zones is arm length and leg reach. Most attacks are done by hand, and that's 60% by hands, 30% by feet, and then 10% by someone doing a headbutt or using their head to move around. Be aware that the size of the response team to a situation could also escalate that person's aggression. Sometimes people feel that a larger crowd gives them what you would call it audience, so they start to perform and act even worse or differently. So if you do feel that's starting to happen, it'd be an opportunity to reduce the number of staff that you have standing around to help with the situation. Also be aware of your surroundings and something that someone could use for a weapon, and something that might be on your person. I always tell nursing staff that they have the stethoscopes around their neck. That could be used as something to strangle them with. So those are things just to be aware of. Always strive to de-escalate the person, to try to get them calmed down. That's always the best outcome, but always be aware that a physical intervention could happen. Okay, Phil, next slide. Going on to an active shooter description. An active shooter is an individual that's engaged or attempting to shoot a lot of people in a confined area. And you can think back over the years of active shooter events, the Columbine high school thing happened many years ago. That was probably one of the biggest and the first ones that really started setting things in motion and making change. They get notoriety, they get a lot of publicity, and they did it at the beginning of these types of things, but not so much anymore. We do find in hospitals and healthcare settings that the active shooters or the shooting situations are directed or focused at a person. Active shooter events in healthcare situations aren't that prominent, and it's usually directed at a person. Active shooter situations, it says here, they're unpredictable and they all evolve quickly. I do somewhat disagree with that statement, because I think, and as we get to this, a couple slides in the program here, point out some of the things that we can all look for. And if you notice in some of the previous active shooter events they've had, where they've interviewed neighbors or they've interviewed parents or any other folks that are around the person, they found that the person was doing some strange things. Noticed that he was been acting pretty different in the last month or so. All of these things are escalating the behavior that people notice, but they don't speak about. So go back to another Homeland Security piece of see something, say something. So especially in today's market. So always be aware of those things. Typically an immediate response from law enforcement or armed security staff is needed to stop an active shooter situation. Set in a bigger environment where there are a lot of people, that the shooting could take place every 12 seconds. So time is definitely of the essence. And the quickest response is actually a response of on-site staff that might be armed security or law enforcement. Active shooter situations are usually over in 10 to 15 minutes. That's not much time, but that's about what it takes for an active shooter response from law enforcement, unless you have folks that are really close. I'll talk about a couple situations that we had here in our community and the response time on those as well. Staff need to be prepared both mentally and physically to deal with an active shooter event. And that goes back to the part where I was talking about policy and drill. When you drill, you'll find that some staff get pretty uncomfortable. So just take that times 100 of what would happen during a real event. That's why it's so important that when we're getting the policy out there, that we don't just throw it out and let people read it. We really need to go to the point of explaining, try to define to them what it means and why we have created such a policy for the facility. I do some orientation training for new employees, and I often point out to them during all the code trainings that these codes are really important, but the most important time is when we have an event. It's easy to understand what a fire alarm is, but until we actually have an active fire, that's when you get put to the true test. So it's in an active shooter policy, it's best that we work with that over and over to try to make sure that staff are, sorry about that, are aware of what they would be doing. The repetitive training is always the best for people to understand. Okay, that's good, Phil. Let's move on to the next slide. These are the types of persons that will be doing an active shooter type thing. You said they're seeking attention, and for healthcare, they're actually directing their focus on one person. We're finding that person could be staff, and in that it's a clinician, a nurse, maybe a soon-to-be ex, could be a physician. It could be a physician because of prior care for a loved one. So In healthcare, it usually is focused on that one person. A lot of times they try to create chaos and do things to distract people along the way, pulling fire alarms and so forth. Most they have found more introverted, kind of coward people that had a lot of planning and a lot of time to plan such an event. Most take their own life when they're confronted by either staff in the facility that go after the shooter or by law enforcement as they arrive. Some take their own lives and some confront law enforcement with a bad ending. High risk areas, as I pointed those out earlier, and you can see ours here in Reid. People may not understand how much flack HR gets. HR departments get a lot. Administrative staff gets a lot too. Obviously, critical care areas get a lot. Parking lots and parking garages. Now here at Reid, we don't have a parking garage. I know a lot of facilities in Indiana do, and those are kind of hard to watch places and areas of concern. Obviously, pharmacies and any retail base that you would have in a hospital could be those as well. Rural standalone facilities, I think, are critical places as well. And like I said earlier, those are areas where you need to get involved with your local law enforcement. Become friends with that group. Okay, let's see. These are some of the behavioral things, and I'm not going to go through the whole list, but I always really try to point out to everybody that these are things that we all see or could see daily in staff we work with directly. Very important. If you notice that you talk to the person. If you can't talk to that person, you need to report that up because there could be something going on, and it could be something that we can intervene with. It could be something that we could help the person with, and it could be something that would need to escalate up to law enforcement, where they might have to do an external type investigation on a person. Could be a friend of yours, just a good coworker, but we really need to watch all these types of things because they do have a trend in turning people to perhaps do some things that they shouldn't do, even up to the point of taking their own lives because the stressors are so high. Another thing that we can all notice right now is what's going on in the world. What's going on with COVID? What's going on with the mandates that some of the government is pushing out, and these things are causing a lot of stress for a lot of people. A lot of healthcare workers are fearing that a mandate's going to create where they have to take a vaccine that they don't want to take. They may decide not working is the best option for them. There's just a lot of things going on in our world right now that could create any one of these behaviors in a coworker. It could be a neighbor, it could be anyone that you're familiar with. But if you see these signs, that's something we need to all step in and try to help out with, or try to change the direction that people are going. Another piece that I found was the FBI had done some research on some shootings, and they find that, and I'm going to read this from an article that I've got. Most active shooter situations like this are single males, and they're not in a romantic relationship at the time of the attack. They had some manner of grievance against one or more individuals at the attack location. They experienced mental health issues just prior, but had no history of mental illness. They exhibited behaviors that, after the fact, could be construed as pre-attack indicators. And that goes back to some of the things I was talking about earlier, that if you see people's behaviors change, those are indicators that something's going on that maybe we can help out with before it gets to a point that it's too bad. 3/4 of the individuals in the active shooters spent weeks of pre-planning what they were going to do in their attack. And it further says only 1/4 of all those folks were previously diagnosed with some kind of a mental illness. Stressors that cause these things to happen for people are financial, physical health concerns, interpersonal conflicts with family and friends, with colleagues, mental health issues, and criminal or civil lawsuits, and substance abuse. So those are all things we need to kind of keep track of and look out for. On to the next slide. Staff's response. Once again, it's going to be defined specifically by the department plan. And I like to tell folks to keep the department plan very short. It's just something that staff need to know what to do when that event happens. You don't need to know all the information about setting up incident command or who to contact after the event. The important part is what to do right now when that event is happening. Some of the top pieces we have here, we try to close all doors to patient rooms. Try to close hallways as best we can. Try to create barricades and barriers for anybody that might be coming our direction. In our facility, we have prox access doors on all of our nursing units, and they're all set to be locked all the time. So in the morning when staff come in, they're able to open the doors with their prox cards, and they then hold them open with magnets. And if there's a fire event, those doors will release. But during the day, these doors can stay open, so visitor access is easy. Staff can move around the facility easy. But if there were an event like an active shooter, all that our staff would have to do is shut the doors to the entry to their unit, and that would create that barrier that we're looking for. So that's a big piece, and that's I feel like that's a very important piece for us to have here. If you're in an office, you need to stay or find someplace that's secure. You need to understand too the difference between cover and concealment. Cover is an area where you can actually be hidden, and it would keep you from getting shot. So a big tree, for instance, is not going to let a bullet pass through. So that is considered cover. Concealment, on the other hand, is just something that you can hide behind so the person can't see you. A good place to be if you don't have cover, but there is a difference. You also want to, when you're securing yourself, you want to make sure you turn radios, phones, and things like that off. Try to be as quiet as you can, and stay out of the active shooter's view. Try as best you can to remain calm, and also don't trap yourself if you can keep from it, by letting the shooter be between you and any exit point of wherever you're hiding. Because if you do that, then you have lost the element to escape if that ever gave you the opportunity. Stay in that secure place until you get assistance. Under no circumstances you unlock an area until you're very confident that the situation is over. And as a last resort in this piece here, we don't want to try to attack an active shooter unless it's just at the very last second and they're right here and you're possibly the next victim. You want to do everything you can to try to incapacitate that person. Find things to throw, yell, be as loud as you can, be angry, and commit to what you're going to do to survive. Go back up a couple bullet points too here, that if you do lock yourself into an area, at that point, it's not time to just sit there. At that point, you've got to devise a plan of what you might do if the person gets into the room. You have to have some kind of a response at that point. Activation. This is how your plan is going to be activated. It needs to be universal for the facility, so everybody knows when they hear that they know what's going on. The response plan 2 for employees is, what are they going to do if they're hiding? What is the clearing code? Make sure they understand that specifically. Here at Reid, we have a situation, or our switchboard puts out a word or a phrase, and that goes to everybody's phones, that goes to everybody's devices, so everybody would understand what that is. Recovery after an event like this, you're going to have facility debrief, so everybody can come to that. You're going to account for patients and staff, EAP support, employee assistance folks. You're going to need all of that, all you can get. Staff involved directly would also need to communicate and work with law enforcement as well. Going down, Phil, if you would, to what to expect from law enforcement when they arrive. I think it's 2 slides down. Next slide. I'll go through next slide. I'll go through these real quick. Law enforcement they're not gonna stop for injured or wounded. They're gonna move straight through at your direction or wherever they hear gunshots. They're not gonna stop to help people that are injured. Usually 2 people or 2 officers are gonna arrive. Law enforcement's response changed greatly after April of '99 in the Columbine situation. If y'all remember Columbine, they all got there. They kind of waited for SWAT to arrive. The day after that, things changed in the law enforcement world. No longer wait. When an officer arrives and there's shooting going on, they go in. Next slide. Kind of running out of time here. I talk too much sometimes. When they arrive, you need to remain calm. The biggest thing and the most important thing is don't have things in your hands. Don't have bags in your hands. Have your fingers spread apart like this, hands up, so that the officers can see it as they're passing you. Don't make any quick movements towards an officer. That could get you hurt too. If you're trying to escape or get out of the building, you always want to go in the direction that you saw the officers coming in. And that is all I have. A couple of statistical things real quick. From January to June of 2020, there were 22 healthcare shooting events. 21 were in a hospital, and 1 was in another facility, which would be an off-campus type building. 7 were inside, 15 were outside. 10 people were hurt, 13 people were killed. The shooter 19 times was a male, 1 time was a female, 2 were unknown. 2019, there were 61 events, 45 in the hospital, 16 in other, 20 were inside of the hospital, 37 were outside, 21 people killed, or 37 people killed, 21 hurt, 47 males did the shooting, and 5 females, 5 unknown. From January of '09 to December of 2018, there have been 266 people hurt and 376 people killed in hospital healthcare shootings. Once again, I go back to the first point that I believe this is because it's healthcare, not reporting like they do on the nightly news, and not really considered active shooter events. And with that, I know I'm out of time, so.
Well, we certainly thank you, Chief Kolentus, for sharing this. This is incredibly good information for our attendees to have and understand. We've got about 1.5 minutes. Are there questions for Chief Kolentus while we have him here?
There was Phil, a question that came to me. We have minimal security at our critical access hospital, and in fact, I'll add in, we have a few that really don't have a security department. What should we make a priority in developing our plan?
I think it would depend on the size of the facility, but if it's a smaller facility, I would look to finding the quickest exit points and put your plan around that, and find out where the shooter might come in. If they have no access except through the front lobby, that's going to be a critical area, and those folks need to know how to de-escalate. They need to know what they could do really quickly to notify everybody else in the facility of what's going on, and how they're going to escape as well. I would still reach out to local law enforcement. I think that they would truly like to be involved, and if you ask them for that, that would make them feel good as well. And I think they could help you with a plan, and maybe even work with training your staff.
Okay. Thank you, Chief. Other questions?
I don't have any other questions in the queue at this time.
Okay, I just have one quick question, Chief, and then we'll dismiss for the break. You mentioned doing drills in the hospital. I assume that's done, it has to be done at times when patients are around. If you could just in a 60-second window, tell us how that works with patients and how you minimize impact.
Okay, yeah, a lot of planning goes on with that. We have our community relations team involved. They make sure the community knows what we're doing on a particular day. Reach out to the 911 center. We contact all local law enforcement so they know what's going on. We actually have a contact point from the 911 center to our hospital, one person. That way, if somebody calls inadvertently to the 911 center and says there's an active shooter, they contact that person immediately. We have lots of volunteers that come that day, and they have signage that they walk around our hospital with, and with the person that's portraying the active shooter. Just a lot of pieces in that. It's not a bang bang fake gun, no guns actually, but just to approach the staff to see what their response is.
Okay, thank you very much. I appreciate you clarifying that. Again, thank you for your time. Thank you for being with us today. If any attendees would like to speak with Chief Kolentus, please email us and I'll be glad to provide his contact information. Thanks, Chief. We appreciate it again.
Thank you.
Thank you.